Good afternoon all. Welcome to our session, Small Pupil Crisis, What to Do. First of all, I thank KSOS and the Scientific Committee for giving us this opportunity. Non-dilating pupil or small pupil demands careful surgical planning, and we have experts from Trivandrum to Kannur to discuss various methods to overcome this issue. Our speakers will be there here in a short while. Now, small pupil means usually pupil less than 6 mm. But this measurement, it's a relative one that depends on the skill of the surgeon. For an expert, even a 5 mm pupil is enough for a safe surgery. But for a beginner, you need a larger dilated pupil. And also it depends on the NS grade. If it's a black cataract, you need a larger pupil. For all of us, even a 5 mm pupil, for a soft cataract, that is safe. And even if pupil is 6 mm, but the iris is floppy, we are going to have trouble. We'll get intraoperative floppy iris syndrome. So we need a larger pupil there. So it's a relative measurement. And the causes of small pupil we usually come across are pseudoexfoliation, posterior sinus K following uveitis, topical miotic therapy, diabetes, and the new villain is tamsulosin. That is an oral alpha blocker. The urologists use this for relaxing the bladder neck smooth muscle, but here we will get intraoperative floppy iris syndrome. Now, when the pupil is small, naturally our rhexis will also become small, and then there will be complication in all further steps. Like when we are doing hydrodissection, there is chance of FPC burst and nucleus drop. And also when we are doing nucleus management in SICS and in phaco. In SICS, there will be difficulty in prolapsing the nucleus from the capsular bag to the AC. And for phaco, there is difficulty in horizontal chop, and there is high chance of injuring the iris and even the rhexis margin. There can be bleeding from iris prolapse, and studies have shown that the risk of posterior capsular rent is 50% higher in small pupil. And next step, during the cortex management, there will be incomplete cortical cleaning. We cannot see what is behind the iris, so there will be incomplete cortical cleaning, which will lead to posterior uveitis and posterior capsular opacification. And regarding the IOL implantation, we don't know where we have implanted the IOL, whether it is in the bag or in the sulcus or half in the bag and half out. So there also problem. And postoperatively also, there is high chance of capsular phimosis and late IOL degeneration. So this small pupil definitely needs careful surgical planning. And I have Dr. Reshmi, an young enthusiastic phaco surgeon, my own student. She will be discussing on non-device options to manage small pupil crisis. Over to you, Dr. Reshmi.
Good afternoon, all of you. First of all, I would like to thank the KSOS Scientific Committee and Cinemol Madam for giving me this opportunity. Here I am talking about non-device options in small pupil. So the goals of pupil management in cataract surgery is to achieve adequate pupil size for the cataract surgery and also to maintain good pupillary function as well as cost basis. The key factors for this process can be divided into 3 steps: preoperative assessment, pharmacological and non-pharmacological methods. Pre-operative assessment is very important because we should identify the patients who are at risk of developing small pupil during surgery. Previous history of trauma or uveitis, those who have PXF, those who are on treatment for BPH and diabetes, we should identify. Avoid dilatation 1 to 2 hours before the surgery and stop any miotics 3 weeks prior to surgery. Preoperative medications we usually use topical mydriatic and cycloplegic like T+. NSAIDs can be given 30 to 90 minutes before surgery. They inhibit prostaglandin release. Atropine eye ointment has been found to be beneficial in few cases of floppy iris if given 2 to 3 days prior to the surgery. Surgical sponge soaked in 10% phenylephrine can be kept in the inferior fornix 30 minutes before surgery. Coming to the intraoperative methods, these include intracameral drugs and various devices. The intracameral drugs have the advantage that they don't have any adverse systemic side effects and they have direct contact of the drug with the target tissue. Coming to the pharmacological methods, the first one and the most commonly used one is epinephrine 1 mg per ml, 1:1000 solution. 0.1 ml is mixed with 0.9 ml of BSS and to make it 1:10,000. Second method is also using epinephrine, but we mix 0.5 ml epinephrine in 500 ml of BSS. The advantage is that the concentration of the drug is not lowered during the procedure and only a lower dose of drug is needed than a single initial injection. Next method is using 1% preservative-free lidocaine injected into the anterior chamber. This causes topical anesthesia of the sphincter pupillae and the dilator become uninhibited. The next method is a combination of tropicamide, phenylephrine and lidocaine, which is now easily available in commercially. 1.5% phenylephrine intracameral is another option. Episugarcane is a combination of 9 ml of BSS, 3 ml of 4% lidocaine and 4 ml of epinephrine. Omidria is another method. It is a combination of 1% phenylephrine and 0.3% ketorolac. This can be added to the irrigating solution. This doesn't add to pupil dilatation, but it can prevent pupil constriction. This improves intraoperative and early postoperative patient comfort also. Now, in order to maintain dilatation, we can add 2 drops of 10% phenylephrine in 1 to 2 ml of BSS or 0.5 ml of 2.5% phenylephrine and dilute it with 1 ml of BSS. Coming to the non-pharmacological methods, first one is the viscomydriasis. It was described by Dr. Robert Osher. Here OVD is injected at the pupillary margin and the iris is pushed towards the angle of the eye. The only problem is that the effect is short-lived and the OVD has to be replenished in between. Helon 5 or Helon GV is used for the purpose. Always use a topical anesthesia and mydriatic first, followed by viscomydriasis for better results. Next option is the synochial release. If the patient is having any adhesions or the synechiae, it has to be released prior. Iris spatula or a blunt instrument is used for the purpose. Perform lysis prior to pupil dilatation. Helon 5 may be used later for the dilatation of the pupil. If there are any membrane adherent to the pupillary area, it has also to be released. Using capsulorhexis forceps is better. Carefully tear away the membrane from the pupillary margin. Avoid causing iridodialysis and injury to the anterior lens capsule. Some amount of bleeding is expected during this procedure. Another option is multiple sphincterotomies, usually 6 to 8 in number. They should be equally spaced, 0.5 mm extending into the pupillary sphincter. Avoid too much extension into the iris trauma as it can result in permanent mydriasis. Stretch pupilloplasty is another method. This is done using Coughlin hook or Y hook. The instruments are introduced through the side ports and the pupillary margin is hooked and stretched 180 degree apart towards the limbus. The same procedure is repeated 90 degree apart. This produces micro tears of the sphincter and allow for greater dilatation. Next is the Beeler device. It is a one-hand device which produces 3 to 4 point stretch of the pupil. It has 2 and 3 pronged version which can be inserted to 2.5 mm and 3 mm incisions respectively. Here, the Beeler device is inserted through the main incision. The first hook wraps around the subincisional pupillary margin and then upon pushing the plunger, 3 more hooks emerge. They hook the distal pupillary margin. So, in one stretch, the entire pupil becomes dilated. The Beeler pupil dilate distribute the tension uniformly throughout the pupillary area so that it will not produce any pupillary deformities. Patient will have a better cosmetic effect after the surgery. The precautions include, while you introduce and remove the device, the proximal hook should always be inserted and removed sideways, otherwise it can damage the corneal incision. Also be careful not to injure the anterior lens capsule. So, for a small pupil dilatation, the stepwise approach include first go for pharmacological methods, and if not responding, go for viscometriasis. Always go for a synechial release or membrane release if it is there. Pupil stretching and Beeler device comes next. If nothing is responding, go for pupil expansion devices like rings or hooks. Thank you for your kind attention.
Thank you, Dr. Rashmi, for the informative talk. We'll have a discussion towards the end of the session. Next, Dr. Srini. Okay. He's our scientific committee chairman. Okay. So, which pharmacological method you prefer, Dr. Rashmi?
I prefer epinephrine. Epinephrine, 1 mg per ml.
What is this omidria?
It's a combination of phenylephrine and ketorolac that is added to the irrigating solution in order to maintain dilatation.
Is it available here?
Not it is just introduced one, not commercially available here.
Yes. We,
So you don't prefer that, right? Can you see? Yeah.
Preoperatively, always apply tropicamide plus. If it is not responding, intraoperative, first I go for epinephrine.
You do. Share this folder and open total folder. Yeah. Okay. The video will play, right? Well, I'll continue the discussion on. So I'll basically continue the, where you have ended. Yeah, thank you, Dr. Sinimal, for including me in your instruction course. Basically, I prefer to do surgeries without any devices. So this is a small pupil. Exactly what. Hey, where is the lab? Okay, so this is a small pupil. See, many of these patients I see on table only. You don't know if it is going to dilate with. So what I basically use is phenocaine, no financial interest. So just put it in, and the concentrations of everything in tropicamide and everything in that is so low that. So this is another case. Small pupil on table. So I decided to do the same maneuver. Inject phenocaine in. So it is dilating. But is this enough for me to do a surgery with this thing? See, whatever it is, if you do it in a small pupil, stain the anterior capsule with trypan. Because see, you're going to do the rhexis, and the rhexis has to go under the pupillary margin and go around. So now effectively we will get a rhexis which is larger than the pupil. And I don't know why my first this thing is to go for surgery without any devices. Time factor basically. So see when you're doing a surgery like this, make sure that the phaco tip doesn't go near the pupillary margin. If it goes near the pupillary margin and one catch, then you had it. Throughout the surgery, that iris is going to come to the phaco tip. So if at all you have to go there, just push the pupillary margin to one side and then do it. And even aspiration is difficult. This is another case. It was not a small pupil. So I started the rexes, and the iris started coming down, and pupil constricted a little bit. So here I decided to put an iris hook. See, it's not the classical way in which it is described. So I initially decided to put the iris hook on either side of the entry, the tunnel. So here the rexis has been partly done. So you have to be careful. See, this is a very flexible hook, polypropylene hook, and it has got the stopper, silicon stopper there. So, so you go hook the iris pupillary margin, then hold on and advance the stopper. So the pull should not be in such a way that you have a full dilatation there. So if at all you want a maximum dilatation, it has to be done after everything has been put. See the entry there. So it is posterior limbal. So why I'm doing a posterior limbal? Because pain would be there in a topical lens here. You can see the blood there. It's because I gave a posterior subtenance. See, no egos there. See what the result is there. That's what concerns us. So here it's just posterior. It's on the other side of the tunnel. So why do you go posteriorly? See, if it go more anteriorly, you're going to tent up the iris and it's going to come up. Especially if it is subinterstitial, you put the hook subinterstitial or on the sides, and if it tends up, you will hit the iris every time you go in. So that is something that we don't want. See, it is just a posterior limbal here, and when you put in, see, it is here. See, I always like to hold that stopper there because it's such a soft material. When you just hold on to that polypropylene material and push it, it might not easily go in. So see here, here again it is posterior limbal. See, why you should not go very posterior? Because you find it difficult to push it in because conjunctiva comes there. And see, the direction of the paracentesis is not parallel, it goes down towards the pupillary margin. Again, to prevent the tenting. So once this is in place, then you can do the surgery comfortably. So phaco done. See, everything goes off smoothly. See, the biggest problem I had when I started doing this iris hooks was how to take this out. See, some literature says you just pull it out because it's a soft material. But whatever said and done, there's something there and you're going to injure the pupillary margin. So always withdraw the stopper, then push the iris hook inside so that it is away from the pupillary margin. You turn it around. You turn it around that when you pull it, it doesn't hit the pupillary margin. So in the last one, I'll make it much clearer. See, I pulled it up a little bit more. See, hold the stopper, push it in, turn it, then just pull it out. So it makes the surgery so simple. See, result-wise, this is good. The disadvantage for me there is like you have to make 5 entries, put the thing in. It takes much more time than what I do. Like, see, I should not be telling this like as time. For me personally, it matters because of the volume that I do. And the good thing about this iris hooks is that it's not expensive, and it is not easy to put this other pupil expanding devices in a shallow anterior chamber. There you can easily put it. So I'll just summarize whatever I've shown here. So the incision, like you have the side port, say MVR blade, or I use a slit knife, which is not to the liking of many people, but I'm used to that. So it has to be small. They say 1 millimeter. You can't actually measure 1 millimeter. It's the smallest this thing. Then, see, I said about the angle. Yeah? See, the angle, if it is like this, it's going to cause tenting. So, direct it towards the pupillary margin, then you'll have the slanting one, then that tendency for tenting is not that much. Whatever maneuver is there, you should have enough space in the anterior limbus. So, use viscoelastic liberally. 4 or 5 hooks, don't bother about pentagon, this, that, and all. Then again, I mentioned it during my presentation. You just hook it there. Don't pull it to an extent that it's pulled too much. See, the biggest problem, like I'm putting it at 3 o'clock. See, when you put it at 3 o'clock, the whole iris is going to come here. That pupillary margin is also going to come. So it will be very difficult to put the hook there, and also a lot of undue stretching, and you'll have, if you do that, you'll see a lot of sphincter tears at the end. So one by one you keep it there, hook it enough so that when you put the other side port, it doesn't come off. So, so that is one more, exactly what I said now. And to remove it, you make sure that it is loose. Hold it at the stopper, push it in, turn it, and then bring it out. Forget about what some big people have said in their articles, just pull it out because it's soft. No. It causes iris trauma, pupillary sphincter tear. We just pull it out. Thank you.
Thank you, Dr. Srini, for that excellent videos and the tips, especially regarding the side port incisions you make for introducing the hook. Should be at the limbus, directed slightly posteriorly. But any chance of iris prolapse through that incision?
You don't have to actually, you don't, see, if it is a severe eye phase, whatever small thing you do, it is going to come.
Yes.
So that you can't really anything. It is going to be difficult, but make sure that it is too small. If it is just a pure small pupil, it's not going to come.
Okay.
Absolutely not going to come.
Then another point, can we put all the hooks in the AC and then adjust, hook the iris and adjust
No. See, I don't know. I don't have such steady hands that you put the second side port, that the other one doesn't move. No, I put it just in the pupillary margin, just hook it a little bit so that it doesn't move when you make the other side port.
Okay.
So that's it.
And any experience with the SICS and iris hook?
It is very difficult actually to do SICS with iris hooks, but for recording purposes, see, SICS I might do small sphincterotomies and do it. Sphincterotomies for a phaco, it might cause trouble because the iris pupillary margin might become floppy at that time and hold it, but SICS, it doesn't matter. And if it is a very stiff pupil, you put iris hooks, you'll have small sphincter tears. SICS, I have done. The important point there is, when you do the nucleus delivery, release it.
Yes.
Okay, otherwise, it is going to be a mess. So, release it. And that is also tricky. When the nucleus comes, will it bring the hook along with it and touch it? If you are scared of that, remove the proximal ones, totally remove it. See, once it is SICS, the big nucleus comes out, you will have enough space in there for IOL implantation and cortex wash. That won't be much of an issue.
Okay, thank you, Dr. Srini. As he is our...
JP sir,
okay.
comments sir, on your experience with iris hooks.
Yeah, with iris hooks, I feel one point is we should never hook to the limbus. We need only about 5.5 in my hands, 5.5 or 6 mm. So what I do is I put 4 side port incisions, as he rightly said, closer posteriorly at the limbus, 4 incisions. Then I introduce, as Cinnamol said, all the 4. Then one by one I insert. First round I slightly increase it to about 4. And then I tighten up a little more and increase it to say 5.5 or 6. That is how I proceed. And always inject. One point is always inject visco under the iris before you hook the pupil ray margin, so that you don't poke the anterior capsule. And SICS, I do have black cataract small pupil, means I am terrified. I am more comfortable doing phaco rather than SICS, but in that situation I always use iris hooks. But the sub-incisional hook is always placed right from the sclera, very posteriorly I go in. So it is very deep, very close to the iris root, comes in and takes it out, keeps it back, and that hook I always stretch fully. So that once the nucleus tip comes up, then you can take out the nucleus without damaging the iris. These are the things that I practice. Thank you.
Thank you.
Thank you, Dr. Srini. Next, I invite Dr. Jayaprasad Bhaskaran, our JP sir. He doesn't need any introduction. He is one of the pioneer surgeons of phaco in Kerala. I still remember his teaching in 1998. Do phaco in immature cataract through a well-dilated pupil. That was his teaching. But today we have small pupil, and sir will tell us how to do it with the rings and hexagons. Over to you, sir.
Thank you, Dr. Sinimol, for this opportunity. I also want to thank Dr. Srini for this. Dr. Smita, my wife, was extremely happy when she heard the topic, so that she doesn't have to remind me again and again about rings and hexagonal diamonds. I have no financial interest either in the diamonds or in the equipments and instruments I am going to share with you. See, operating in a non-dilated pupil with experience you can achieve, but there is always, your heart is in your mouth, and you always have the risk of going and damaging the pupil, damaging the endothelium, damaging the PC. And you do not know exactly where you have implanted the lens, and at times you may see, surprisingly, post-operatively, the lens may be half into the anterior vitreous. And if you look at the challenges that the IOL, the iris hooks give you, you have to put multiple paracentesis. You can have subconjunctival hemorrhages, the eye will look red the next day. If your incisions are more limbal, then you can have subconjunctival chemosis, the fluid will get welling up, so visibility becomes poor. And the outer ends of the hooks can go and hit against the lids or onto the middle canthus, and then the inner side can go and damage the pupil ray margin. And the people who propose and sell hooks say that there is a higher risk of infection with iris hooks, which I do not agree with. There are a variety of pupil expanding devices other than the iris hooks, which I have used quite a lot. And Malugin ring, Dr. Malugin incidentally is a friend of Dr. Sinimol, and she always tells me to talk about Malugin, but 10 years back I used to bought at 6,000 rupees one piece, used on about 4 or 5 patients. It's for in my hands at least I feel it is really traumatic. So let me confine today's talk to just 2 of them which I regularly use, namely the BX ring and the Inova ring. Now these 2 rings in my hands gives consistently predictable outcome, and the constant pupil size that they give and the red glow that I get makes my life more comfortable in all types of cataracts, particularly soft cataracts. BX ring, as you know, is from Dr. Suvan Bhattacharya, my friend from Calcutta. We were together at Jimma, so 20 years back, 25 years to be precise. This ring is actually a thin nylon ring. It's very difficult to see, almost like a hair, less than 0.1 millimeter. It's very light, so it floats. And the overall size that you will achieve with this is a 5.5 expanded pupil, a stable 5.5 expanded pupil. And this has got flanges and small notches at the edges. So you have notches at the edges and the flanges. Alternate flanges, that is this one, this and this will go under the iris, whereas these ones will remain above the iris, and the these notches will engage the pupillary margin. Notches engage the pupillary margin. The alternate flanges will go above and below the pupillary margin into the iris. So one of my first cases I will show you, few years, BHEX with Sinski's hook. Those days I was against this manufacturer selling the 23 gauge forceps. So I used to use a dialer, the Sinski's hook, catch that central hole, push it down and gently tuck it under the iris. Always remember to inject OVD under the iris so that you don't poke onto the anterior capsule and create a tear. Then you go to the second one. I am struggling. Actually, this is a fast forwarded video. I struggle. This is a struggle actually. The first few cases are always a struggle with any surgery. Ensure that both the ends are engaged, both the notches are engaged. Now it is not coming out, the Sinski is not coming out. You go through the side port and tuck it in. You see that one notch didn't go in, so brought it up and now tucked. Now we come to the last one. The last one is the biggest problem, the biggest struggle is the last one. Brought it in with my Sinski's hook, bimanually lifted up the iris and tried to insert underneath. So that gives you a reasonably 5.5 mm hexagonal opening for you to complete your emulsification. It doesn't interfere, because of its thin profile, it doesn't interfere with your emulsification, cortex aspiration or your IOL implantation. Here implantation is under continuous irrigation, not under OVD. And once that is done, the lens is in place and you are sure that the lens is nicely placed, then you can go with your dialer, and taking out is relatively simple. Pull it forwards towards the center, 1, 2, and then both the ends are released. Rotate a bit and bring it to the anterior chamber. Because it is under fluid, I bring the irrigation handpiece right across the anterior chamber and keep that nylon ring from coming up and hitting the endothelium. So I am keeping it right across, otherwise it will swirl and come and hit the endothelium. Go in with your forceps. This is a 25 gauge forceps from my VIA surgeon. Catch and simply take it out. This comes out through a 1 mm incision. And you leave behind a round, nice, reacting pupil. So BHEX ring produces minimal complications. That is the truth in my experience. Dislodging is possible very rarely in large eyes, in myopic eyes. When you introduce your phaco handpiece, the AC suddenly deepens. Then what happens is the pupil stretches a bit, the ring can dislodge. There is always a learning curve. So if you learn this in a dummy eyes, which is available, I tell you then how to make a dummy eye, and then it is very easy. And in a shallow anterior chamber, if I am offered a ring, I would like to have a BHEX ring because of its thin profile. But I always choose iris hooks most of the time for shallow anterior chambers. Now this is another case with an intumescent cataract where the space between the iris and the lens is very small. The surface of the lens and the iris are snugly fit. So I went in, I did a small rexis here. Started off with my needle, but then I was not able to continue with the needle, so I decided probably this is a better option to go with your capsular rexis forceps utteratas. And once this is done, all my intumescent cataracts, I do this bimanual IA, go under and take out all the cortex possible from the anterior surface of the nucleus. And once that is done, you know that that capsule is down, way down. There is a big gap between the iris and the capsule. So you put in your BHEX ring introduced into the anterior chamber. Here I am using, finally yielded to that manufacturer constantly telling me to use these forceps. It's a 23 gauge forceps. Opening up and down and not laterally. So you can see that it opens like a crocodile's mouth actually. Catch, twist to one side, engage one end and then twist and get the other end in. See here, you catch, pull it to the center. So one edge is engaged, then you turn and put the other end. And when you go to the last one, always go through the other side. It is ideal to have some instrument through the other side port to support the eye while you are doing this. It will keep the eye in the center and you will be more comfortable. So you catch, bring it to the center, and one end you turn a bit, enter, and then you turn a bit here and enter. So that is all. This is actually very simple with these forceps rather than with Sinski's hook, unlike what I thought in the beginning. And because of its thin profile, this is one patient halfway through I lost the Sony holes, they were very weak. So I stopped, I put in the capsule hooks. It's not possible to put capsule hooks with any of the other devices available today. So that is about B-hex ring. And tips to improve the outcome is, you have to differentiate between whether it is an elastic pupil or a rigid pupil. Rigid pupil, it is very tough to put any of these pupil expanders. Remember that when you inject fluid into the anterior chamber BSS, if the pupil dilates a bit, that tells you that probably this is elastic. If it remains the same, then you will have to stretch. Now, stretching, unlike what you do routinely, only stretch means you stretch to the limbus. But here, if you are stretching, you stretch only to 6.5 or 7 mm, 1, 2, 3, and 4. 4 stretches you should do. Very minimal stretches so that you will have only very small tears, so that pupil will remain round, even come back to normal and react. And always remember, whatever expander you use, including the iris hook, inject OVD below the iris and underfill the anterior chamber, not overfill. If you overfill, the iris is going like this. Remember, in high myopia, when you go in with the fluid, the iris goes like posteriorly and you get a reverse pupillary block. Similarly, it goes down so there is no gap, and then you can injure the anterior capsule. Innova is the new kid in the block that is from Orolab. It's a pupil expansion device made of medical grade silicone. I used to use a ring to do my rexes called Verus ring. This is similarly like that, except that this ring engages 360 degree of the pupil with no pupillary distortion, and they give an injector, a simple injector. It gives you a diameter of 6.3 millimeters inside the overall diameter, and there are four positioning holes where you can use your Sinski's hook to introduce and to remove. And on the sides, it has got a groove 360 degrees, so that will engage the pupil all around, so there is no severe stress at any point which will damage the sphincter. So let us have a look at it. This is the injector that they give. I know a pupil expander. You push it in, and then you use your dialer to take it completely inside. Once it is inside, you catch the positioning hole and engage the pupillary margin. When two adjacent holes are engaged, the iris margin in between gets into that groove and sits there. Now it is absolutely round and stable there. I found that this is stable. You make a rexis which is slightly within this, because this is 6.3, you want only 5.5. So use this as a marker or a scale to make your rexis. So that is one additional advantage of having this Innova ring. And it doesn't interfere with your phaco handpiece. It doesn't interfere with your IOL implantation. And finally, to take out, inject OVD. After the lens is dialed into the bag, inject OVD and pull it in. I tried a new technique of pulling from both the sides. This is all more or less the same, because I generally don't like with these rings, any ring for that matter, when the iris goes into the ciliary body area. But here I tried, but then it's more or less the same. So it comes out, and then you can pick it up with your forceps. This is another case where I tried injecting with the injector itself. Once I went in, it doesn't go in completely with this injector. You draw back, you inject a second time, it goes little more, and with a third push, definitely it goes in, and then the procedure is the same. The disadvantage of the Innova ring is it's thicker, it's a thicker profile. So in very shallow ACs, I don't think we should be using this ring. But the advantage is it can be used multiple times. For a person in private practice, it can be ETO'd or autoclaved and can be used multiple times. And you can use a subject fixated, coaxially sighted corneal light reflex to center your rexis by using this ring initially. And always remember that any form, wherever you are touching the iris, use more of steroids. Always remember this. And in situations where there are large PC runs and where there is solar dialysis, it is always hooks and never rings for me. With that, let me stop here. Thank you so much. And you can punch out actually small elastic materials. That hole comes to about 4 mm on a scale. And you can use your B-hex ring, used B-hex rings in your ring, and you can practice on this, a plastic ring, which you can stretch on a ring and keep it, and you can practice. If that helps a lot, do it whenever you want to go into rings. Thank you so much for your patient listening. Thank you, Cinemol. Thank you.
Thank you, Jayaprasad sir, for that good videos and excellent presentation.
Sir, one doubt. Which one is comfortable for you, sir? Whether it is B-hex or this Innova ring?
No, I know what they gave it to me for evaluation.
Okay.
I've done only very few cases. Cost is around 2,000 rupees.
Yes.
BX is around 1,800 if I remember right. But you have to buy 7,000 rupees worth of that forceps. But thinner profile has a definite advantage, I feel. And so I think if the AC is not shallow, you can go in with I now. It's a good ring. Thank you.
Thank you, sir. Next, I invite Dr. Sai Kumar, sir.
Sir, one more doubt. What is your preferred method in mature cataract small pupil? Whether it is Coghlan's hook or iris hook or rings? Mature cataract, non-dilating pupil?
No,
any
mature
preference?
cataracts, with a small people, yeah. You would have seen that I always do a small rexis before I touch the pupil. Before I touch the pupil, unless it is really small. If it is about, say, 4 millimeters, I make a 3 mm rexis first. Go with bimanual. I do not use a coaxial. I use a bimanual and go in and aspirate out the cortex. So once that is done, then the capsule goes back. There is a big gap. Then it's my choice as to whether I have to use capsule hook or the BX ring. And then you go in and do your second rexis and then proceed like normal. See, in all mature cataracts, once you have completed your rexis, then it is like any other cataract.
I invite Dr. Sai Kumar, sir.
Thank you. Thank you, Cinemol, for having me in this course. I'm sorry I was a bit late because the executive committee meeting was going on. So I'll be talking about two very specific clinical conditions in which you encounter small pupil. I haven't heard the previous talks except the last bit of JP, but I'm sure most of the devices and techniques would have been already covered. So I'll just briefly go through this. So IFIS was originally described by Chang and Campbell about 2 decades back. It was seen predominantly in elderly males who were taking alpha blockers for benign prostatic hypertension. We all heard about the drug tamsulosin, which was widely used. And then we also found out that alpha-zosin, terazosin, silodosin, which is being very commonly used nowadays, which is now the urologists prefer more of silodosin. But all of them can cause IFIS. There are some drugs like benzodiazepines and antipsychotics which can be used. We are not sure whether stoppage of the drug does make any effect. I have found that stoppage does not make any change, so I don't stop alpha blockers at all for my patients. There are some patients who believe in pre-op atropine. Again, it might work in some, but not a very sure shot to prevent IFIS. The components of IFIS are progressive meiosis during surgery, fluttering or billowing of the iris, and prolapse of the iris either through the main wound or through the paracentesis. And if you are caught unawares, IFIS can be a pretty nasty complication during phacoemulsification. But if you are aware of it and you have taken preemptive measures, then it is easy to manage. So how do you handle progressive meiosis? Preoperative dilating agents, of course. Preoperative NSAIDs, if you are not using it regularly, I suggest that in cases where IFIS is expected, you have to use them. There are many surgeons who use atropine. I don't use them regularly, but surgeons who use it claim that the pupil does not come down too much. Intraoperative adrenaline I use in all cases where I suspect IFIS. Judicious use of dispersive viscoelastics to me is the most important step. I use only Viscoat for this condition, no financial interest, but I find this the best drug to keep the iris away from your surgical field. And of course, all the devices that are being discussed now. How do you prevent the fluttering and billowing of the iris? Again, dispersive OVD is very, very important. Reduce your phaco parameters a bit, although I don't use this in every case, but in severe cases, you can make it look like a slow motion phaco so that the flutter or the circulation of fluid inside the chamber is come down. And you can also prevent iris chafing. Don't go, take out the pieces, remain in the center, don't go too much to the periphery where you can catch the iris. Small iris prolapse, of course, make your side ports and the main wound very tight, just enough for your instruments to go in, and be very careful when you go in and come out with the instruments. And again, OVD, dispersive OVD is a very, very important component. So let us look at 2-3 clinical scenarios. This was actually an ex-minister in Kerala who wanted only femto. His pupil was reasonably well dilated, good enough for femto. So we went ahead and did He also wanted a toric intraocular lens, but we knew that he was on tamsulosin for a long period of time. So here I am just checking the edges of the rexes whether they are intact. I don't routinely make the main wound with Femco in all cases, but the moment I started my hydrodissection, then the iris starts coming down. Immediately it is trying to prolapse out through the main wound, and now this is where I am using viscoat. So use viscoat to just push the iris away from your surgical field and go ahead and do a routine phacoemulsification. It won't cause any trouble for you as long as the iris is kept away from your surgical field. Even during the surgery, you find that the iris is fluttering a bit, but it won't cause any significant problem either during your phacoemulsification or during your cortex aspiration. You can see that the iris has got a tendency to come into the bimanuals, but you can manage without any major complication. So we'll go to the next scenario where the pupil was mid-dilated, and so I used a B-hex ring. I use a micro forceps which is used by our retina surgeons to put in the ring. Just put in the ring like that, and then use a dialer to tuck the ring under the iris. This is the technique that I use. This technique is good in my hands, although there are some forceps that are described by Suven for placing these rings under. I generally use the microrhexis forceps the VR surgeons use and probably discard, and you can take it, and even for removal you can use that. So the iris remains well there. I am not going to show much of the phaco part here. This patient also opted for a toric lens, and at the end you can just use the same forceps to just take out the ring that way. This was a case which was managed by iris hooks. This was slightly older video. This particular case probably I would have used a B-hex if I do it now. I usually use for IFIS, I use 5 hooks. So use a paracentesis just before, underneath your main wound in a different track, and through that your 5th hook goes in. So you have something like a pentagonal iris that is available for you, and this is how the iris looks like once you place the 5 hooks. Initially I was also skeptical of putting in the 5th opening underneath your main wound, but it does not interfere with your phaco or IOL implantation in any way. So these are the ways in which you can manage the IFIS. So the take-home messages for IFIS is that duration of alpha blocker use has no connection. Even patients who have been on 2 months, you can have IFIS. Some patients who are on 5 years, you may not get IFIS. So once you know that this patient is or was on alpha blockers, we recently had 2-3 patients who already undergone surgery for prostate 2 years back, but they were using tamsulosin at some point of time. They also had similar IFIS. Pre-op pupillary size is important. Sometimes even normal pupils can come down, but smaller the pupillary size, the more the problem. Elderly people already have myotic pupils. If they are also on tamsulosin, it adds to the problem. Judicious use of OVDs devices. Never do sphincterotomy or stretch pupilloplasty if you're suspecting IFIS, because it will make the iris more pliable. It will cause more of billowing. Coming to the second, which is pseudo-exfoliation, I call the iris pattern, there is something called a fragility spectrum. So if the IFIS irises are thick and mobile, the pseudo-exfoliation comes somewhere in between. The uveitic iris is very fragile. The moment you just open it with your sphincterotomy or your Kuglen hook, they just stretch. There is a lot of sphincterotomies and it just remains that way. Pseudo-exfoliation is somewhere in between. There is degeneration of iris muscles, atrophy of the pigment epithelium and stroma. Shallow AC is a problem that you quite often encounter in pseudo-exfoliation. So unlike in IFIS where you handle only the iris problem, you have endotheliopathy here, you have shallow AC here, you have possibility of weak zonules here. So a lot of multiple issues you have to tackle when you are doing a pseudo-exfoliation case. This was a mid-dilated pupil, not a very small pupil. I did a rhexis but found out that the whole nucleus was moving around. I managed to do a complete rhexis, but here instead of using an iris hook, directly go in with a capsule hook, so that both your iris and the capsule are very conveniently caught in your hook. This is an external tamponade, as I call it, so you can safely do your phacoemulsification, and towards the end you can go in and implant a capsule tension ring and then go in with your intraocular lens. And while taking it out, please be careful not to hook the edges of the anterior capsule while you're taking out the hooks. This was a case where there was pseudo-exfoliation, small pupil. As I mentioned before, pseudo-exfoliation, you can do sphincterotomy. You can do a stretch pupilloplasty in these sort of cases. So here I try to stain the capsule and use a stretch pupilloplasty here. It behaves something like a uveitic iris. It's not like a IFIS iris, so you get reasonably good dilatation. The moment I started the rhexis, I found out that the entire nucleus was moving around. So this is hook as you go. That means you have a bit of a rhexis you do, put one capsule hook, do some more of the rhexis, put the second one, the third one, like that you can go ahead. This particular patient needed a sutured CTR because the whole nucleus was very, very mobile. The third case is a case where, again, I thought I'll do a bit of stretch pupilloplasty and get away with a routine phacoemulsification. Luckily, the iris did not tear too much, because finally I would require this iris. The moment I started doing my rhexis, I found out that the entire nucleus was wobbling around. There was no way I could do a proper rhexis or a phacoemulsification in this case, and the nucleus was very hard also. So I aborted there. I made a scleral tunnel, and I went ahead and removed the whole nucleus with a vectis. You can see the edges of the zonules, which are very, very weak and stained with trypan blue there. Went ahead and did an inferior PI and went ahead and clawed used an iris claw lens. So for iris claw lens, you should not create multiple sphincterotomies. If the pupil becomes very ragged, it becomes a bit tricky to put in an iris claw lens. But here, fortunately, the iris was a bit pliable. In spite of my stretch pupilloplasty, the iris was reasonably okay, so that I could implant a claw lens. So take-home points regarding pseudo-exfoliation: you have to deal with multiple issues here, like a small pupil, weak zonule, shallow AC, and it's very well documented that pseudo-exfoliation patients do have significant endotheliopathy. They do have significant problems with the corneal endothelium. Capsule hooks may be needed instead of a normal iris hooks. Use of CTR in all pseudo-exfoliations used to be recommended a decade ago. I don't know how many of you regularly use a CTR for all pseudo-exfoliations, even if they have weakness or not. There used to be a time when we all used. I found that over a period of time, it did not have much effect, because many of the pseudo-exfoliations I did 10 years back, 15 years back, with all these things, the entire bag, the iris, the IOL, the CTR, everything started, falling down in some irises. And stretch pupilloplasty is not absolutely contraindicated in pseudo-exfoliation, unlike in a case of IFIS. Thank you for your kind attention, and thank you, Sinumol, for having me in this course.
Thank you, Dr. Sai sir, for that excellent talk and excellent videos. And one point we have to be very careful is that no stretch pupilloplasty in floppy iris, but we can do it in pseudo-exfoliation. And about the sonular dialysis possible for pseudo-exfoliation, we have to be careful. And then iris claw IOL becomes a better option.
When you have really, if you are really going in to remove the nucleus, if you think that phaco just cannot be done, then don't manipulate the iris too much from then on, because you always have this backup of. Otherwise, you will have to go in for a sutured seat, SFIOL
sutured
or a glued IOL. Take, open the sclera, make flaps and things like that.
Okay, sir. The session is over. We can have a short discussion. JP, sir.
Can I ask a question? Hi.
Yeah, Sudeep, hi.
You mentioned putting a CTR in one of your videos with generalized subluxation. So would you think of putting a CTR in the bag and putting a 3-piece IOL in the sulcus in front of that?
This is what we, in that particular situation, I implanted in the bag. But we have been doing in our institute, we have been doing quite a lot of cases where we put in the CTR, then place the IOL on the sulcus and then capture it.
Yeah.
So probably long-term stability is
More.
better with this
The whole
sort of
thing
lenses.
doesn't go down.
The only thing is you will not be able to use a single-piece lens. If you are using a 3-piece lens, use it in the sulcus. Point taken. Perfect time. Thank you very much.
Thank you, KSOS, and thank you all speakers. Thank you. Sir, please collect your certificate.